Welcome, folks, to the meeting. And then, Alex, you will run through our normal meeting minutes and then our roll call, at which point then we will turn it over to Stage Squirrel. Okay? Thank you. So good morning and welcome to the Alzheimer's Disease and Related Dementias Task Force. My name is Ursel McElroy. I am the Director of the Ohio Department of Aging and Chair of the Task Force. Glad to have everyone here this morning. I will turn it over to Alex Lapso to both do the roll call and to handle our meeting minutes. Alex?
Well, thank you, Director, and good morning. Good morning, everyone. As I have previously, I will begin with calling the names of task force leadership, proceed through governor's appointments, afterward legislative appointments, and then lastly, those who are representatives of our executive agencies. Beginning with Chair McElroy.
Present.
Vice Chair Dieferheimer. I'll call the name Dieferheimer once more. I'll now proceed with governor's appointments, beginning with Addison.
Present.
Beach.
Here.
Blau. Bolin.
Here.
Brockman.
Here.
Broad.
Here.
Berman.
Present.
Drost. Hockwalt.
Present.
Johnson. Pakunka.
Present.
Mahajan. Reese.
Here.
Russell.
Here.
Schiffel. Smith.
Present.
Stevick Rust. Thompson.
Here.
Van Runkle.
Here.
I'll again call the name Blau. Drost.
Greg Sini's here as well.
Thank you, Greg. I'll call the name Johnson. Mahajan. Stevick Rust. I'll now proceed through our legislative appointments. Leader Yuko is not able to join us today. However, his staff is here as proxy, so thank you, Kate. Senator Wilson. Representative Creech.
Here.
Representative House.
Here.
I'll again call the name Senator Wilson. Representatives from our executive agencies, beginning with Director Corcoran. Director Ashenhurst. Ombudsman Laubert. I'll again call the names Director Corcoran. Director Ashenhurst. Ombudsman Laubert. Chair McElroy, we do have a quorum.
Okay. Thank you, Alex. And if you want to review the meeting minutes for us, please, for approval.
Most certainly. The minutes have been distributed. I'll give everyone just another quick moment to glance over them. Afterward, I would ask for a motion and a second to approve the minutes.
Move approval.
We have a motion from Pete Van Runkle to approve the minutes. Do we have a second?
I'll second. Lori Stevick-Rust.
We have a second from Lori Stevick-Rust. Are there any objections to approving the minutes as drafted? Hearing no objection, the minutes will stand as approved. Thank you.
All right. Thank you, Alex. So we do have a lot to cover today and in the next few weeks. So I just wanted to first thank everyone for being flexible and understanding that we have a lot to accomplish in a pretty compressed amount of time. As you know, the first year, due to COVID, we did not have the benefit of the entire time frame that was laid out, but we also committed to still getting something out in August. And so our plan is to move forward with a report of our findings of the current state of things by the August date, with a report that would follow ideally within 90 days with our recommendations. So we're looking at a two-step process here, at least initially as far as the reporting. So we will have a report out in August with an understanding that there will be a subsequent report that follows. What that means is for us to be productive is that we will have to increase the meeting cadence, hence the message that you should have received, I believe, last week. The cadence will be, obviously we'll meet more often and our meetings will be a bit longer. So to the extent that you're able to accommodate that, we are hopeful that you will be able to participate. We think that this is fair in that we are still trying to stay within that time frame of meeting August and the time that you had committed to for this first report to come out. The second thing is we are very interested, as you've heard me mention before, in ensuring that we have public engagement. And public engagement, from my perspective, is one, making sure that we have families and individuals who are experiencing living with the disease, but also those individuals who are expert or professionals working in this space. And so what you will find in working with Sage Squirrel is that we have set forth a week where we believe that we will be able to have that engagement with those professionals. More details on that to come, but we have identified 6 possible dates and times for engagement. Those 6 dates and times will align with the different buckets that were laid out. I believe, again, that you had an opportunity to receive, and Sage Squirrel will cover some of those here momentarily. We did add a 6th bucket, and that 6th bucket does include equity. So there are 6 areas that we will look at. And Yonda, I don't know if you don't mind for a second, if you could, for the benefit of the group, just list what those 6 are, the 6 different buckets, Yonda or Leanne. It's certainly fine either way.
Yana, this is Leanne. I have the slide up if you'd like me to do it. I can actually share that slide really quickly if you'd like to see it.
That'd be perfect. Yes.
Okay, give me just a moment here. And is that slide showing?
Yes, it's coming. Yes, there it is. There it is.
Okay. So, and just for the sort of context, what we did was we looked at SB 24, and for those of you that remember the children's game concentration, where you flip cards over and you try to find which ones match, we sort of did that with every single topic in SB 24 and tried to group them into themes kind of chunks of information. And this is what we came up with. This also comes from the early proposal from Sage Squirrel. And then, as Director McElroy just noted, we have equity as a sixth bucket, and we have it here as sort of overarching. We think it really applies to every bucket. It's not a single standalone. So we want to make sure that we're accounting for equity and health equity in each of these categories.
Thank you. Thank you. Thank you. So as we begin to move through this work, you will see that regular engagement, both from the public and again, those who are working in this space. One other piece that we have discussed that we also have committed to, and that is creating a pool of experts or subject matter experts or individuals that we feel that we can on a regular basis consult with for really important information, whether it be around health care, long-term care, just a variety of different topics. We are committed to being able to find or be certain that we have available to us during this time frame those individuals that we can pull information from or consult with as necessary. So I just wanted to come before everyone today to kick us off to say again, I really appreciate your commitment to this work. I want you to hear from me how dedicated we are to this work and how you will see that in the increased cadence, in the amount of time that we'll have to spend together. And there will also be regular checkpoints, I'm sure, in terms of the milestones with the work that we're doing. So if you have any questions or comments or anything for me, I'm certainly happy to take those now, with the understanding that I'm going to turn this over to our very capable consultants who will begin to walk us through this, I think, pretty significant bit of work here that we're about to march into. Any questions or comments for me? Yes, Bonnie, I think I see your hand up.
Thank you, Director.
The virtual hand always gets me, yes.
My only question with the buckets is the use of the term long-term care as opposed to long-term services and supports. And I'm just unclear of what the term du jour is, but I wanted to point that out to folks.
And I think that's a very good point. And I think, Leanne, as you go through or walk through this today, I think that's something I think to be under advisement or something to consider. Thank you for bringing it up.
Yeah,
Thank you, Director.
Thank you, Bonnie.
Any other questions or comments? Okay, if none, I certainly want to step out of the way and make sure we can sort of get started, roll our sleeves up and get moving. So I'll turn it over to you, Leanne.
Thank you. Good morning, everyone. I hope you had a nice weekend. First, I think we just want to say thank you for your understanding. I'm going to sort of echo Director McElroy's sentiments here. Your understanding as we have really condensed this time frame and certainly spent a great deal of time the last few days really trying to mine through the applicable data, the really relevant data for today's conversation. We probably had very ambitious thoughts that we would get that out to you last week, and the week moved forward and forward. And I will tell you that we ended up in a conversation over the weekend. We've really sort of adapted this agenda multiple times so that we really could get to a place where we could hear from you without feeling like we were sort of rushing people through and saying, okay, you only have 30 seconds. We felt like the really important work today was to listen to each of you and really capture your observations and what you know, if you will, what you know to be true, given your experience working in long-term supports and services, as Bonnie just said. And I should note, anything like that, language change, anything that you think requires a different context, please feel free to let us know. We've heard a couple of folks already talk about the language of related dementia versus other dementias, and so we want to make sure we're capturing all of that. And so our process for today, just a little bit different than our agenda says, is what we'd like to do is start with, if we can get through it, we have 3 kind of pieces to do today. We'll see whether we actually get through all of those. The first 2 are related to what we've called long-term care, the long-term care bucket, long-term services and supports, and that's the fiscal impact piece, and then the resource capacity, resource availability piece, and then policies and strategies. And if we have time, we will try to touch on the public safety, personal safety, and legal issues. I admit I'm not confident we'll get that far today, but we'll see how we do. What we'd like to do is we've got a couple of slides. We're not going to run through a big slide deck. Let me just make sure really quickly. Did everyone get the PDF document that we sent out this morning that has the data we're using today? Did anybody not receive that? Okay. I'm going to let me get my participant list up since I can't see everybody on the screen. Okay, if you did not, if you don't have it, feel free to put your hand up and we'll get that out to you. We've got a couple of slides just to kind of frame our conversation, and then we're going to dive in. Yanda is going to be the kind of data presenter, if you will. The process we think we'll use is we're going to sort of pose the question. I have a roster that I'll go through for each set of information. We'll move that around a bit so that the same person isn't starting every time and the same person isn't last each time. That starts to get a little old for folks, I know. We're going to ask you what your observations are, what you know to be true, given the work that you are doing, and what conclusions can you draw from that. For the specific question that we'll pose. And then Yanda and Debbie and Christy, who are all from Sage Squirrel, are sort of monitoring data. And if you can imagine, they probably have hard copies of all of those pieces of data spread across their desk. And they'll be confirming with us if that's data that we currently have. If it's data that we don't have, we may ask, do you have any recommendations on where we might find that data? Or if we have data that actually conflicts with your experience. We do still have time limits. So we're going to ask folks to try to, for the first topic, fiscal, we think probably about a minute or a minute and a half for each person. It's right now the amount of data is pretty limited because we don't have all the data back yet. But we'll start there and sort of see how that goes. So I'm going to pull up a couple of slides if I can. And let me just ask if there are any questions while I'm pulling up the slides here. And when I pull up my slides, I can't see the participant list. So if you raise your hand, I will not be able to see. Well, maybe I can actually. Can you all see my slides? Okay, well then I can see you. Good. Okay.
Yes, we're good.
All right, so we'd like to always start with meeting agreements. Just a quick reminder that we will start on time and do our best to end on time. We've done roll call, and I'll be timekeeping today, so I'll try my best to give you a 30-second warning or so. Reminder that we will just gently interrupt if we need to move on to the next person. Friendly reminder to mute your line if you're not speaking. And I think I shared this with you last week to quote my friend, misery is optional. So please take care of yourself if you need to step away and take a break. We do have a break built in, but please feel free to do that. We want you to feel comfortable and ready and able to participate. So. You've seen the agenda. We've been through roll call. We've done the minutes. Thank you, Director McElroy, again for your welcome. I'm going to review those themes really quickly. You've seen that slide. And then we'll introduce specifically today's themes. We will have the observations and conclusions conversation, and that should get us to the end where we can talk about next steps and wrap up. Okay. And so our question, we think, realizing that we might learn that there's a better way to ask this question, but our questions today really are, given your experience, your observation, the work you're doing, what is happening in Ohio relative to long-term supports and services, specifically for people living with dementia. And when you think about that question, think about things that you know are going well, and you would say we should continue this, and think about things that you know that the system and people and families and providers and policymakers are struggling with, and what might need to be changed or improved. And given that, those observations and the experience that you live in this work, what conclusions can you draw? And again, there are the sort of 3 points we'll try to point out today. Do we currently have data? Does our data conflict? Where might we find supporting data? Okay. And you know what I'll probably do is come back to those questions. I'll leave them up there at least when we get going, so folks sort of know what the focus is. So I'll come back to that. These are the buckets. I think the suggestion for long-term supports and services makes sense, and happy to change that. These might not be perfect buckets, but this was this kind of grouping that we could do based on the themes that we saw kind of woven through SB 24. So early intervention, that kind of public awareness work, healthcare, we know there's certainly significant equity issues in healthcare. Long-term care, long-term supports and services, safety and legal issues, policy evaluation, and then equity stretching across all of those, being woven into all of those. And our purpose right now is to hear the experience and observations that you have, to look at the data that we have, and from that draw findings and make recommendations. This is where we're going to start. There are 3, the references A3, B1 through 7, C8 through 10 are straight from SB 24, just so you know where that language comes from. The fiscal impact on publicly funded healthcare programs, existing resources, including cost and availability, and then policies and strategies. Okay, so that's our really big focus for today. And if we have time and we can get to it, we've called this personal and public safety because there are public safety issues. I understand one committee had a pretty robust conversation, for example, about people who may be creating some public risk by driving. But we also know there's personal safety issues there. For example, people who are at risk for being scammed. And then legal protections, and that certainly falls in with, and again, is pretty embedded with the safety pieces as well. So we're going to try to spend some time on that today. And then, okay, so let me come back here to the reminder of the buckets and our questions. I'm gonna need to actually switch slides because I want to put up the slides for Yonda related to the data. But so our 2 questions: what is happening relative to people living with dementia? Again, what's working well? What could stand improvement? And then what conclusions do you draw? Okay. And we'd like to start here. Let me ask if there are any questions before we get ready to start, and I'll go through the roster really quickly. Okay. All right, so Yonda, I'm going to go through the roster, and let me just check and see. We really have notably one slide for the fiscal impact that you think you were going to talk a little bit about relative to the data request that we're waiting on. So we'll open this up for some quick conversation. Here's the list that I'm going to use, and because I'm going to rotate lists, I'm not going down my screen, but I am going to start with Sally. Sally, I know you also have to step out, so we'll start with you so that you have a chance to jump in here. So we'll start with Sally, and then Lisa Brockman, Catherine, and Bonnie. So those will be our 4 starting points. And then after that will be Tina and Diane, Pam, and Joe. All right, so can I start with
Sorry, I have a question. So I'm just trying to think in terms organically. So if there's something that someone else has that comes up or something that sparks something, so say if Sally says something, do I have to hold, or I mean, I guess I'm looking for something a little more organic to keep it flowing.
Yeah.
So I don't want to, yeah.
Good question.
Yeah.
It probably makes sense to hold just until it comes around to you. But if you feel like it really warrants, I mean, we could certainly ask at the end of each person if anybody would like to add something. I'd like to try and pay attention to time, but I don't want to feel like I'm interrupt or cutting somebody off of sharing really pertinent information. Other questions?
Yeah, this is Trey. Is there a time limit for sharing, just knowing that we are obviously crunched for time?
Yes.
Okay.
Thanks, Trey. Yeah, so for this one, if folks can share in about a minute, again, knowing right now that we have in our hands, we have limited data. The data is forthcoming, but we have limited data to show you or that you can be looking at. So we have more time carved out for the other topics because we had much more robust data there. So. And so that time is about a minute or so. Yonda, did you want to say anything before we start?
Just again, just to reiterate that this is an area where we have made we can make some assumptions about current service usage and current rate structures, and I think any projections that we make will be based on that. But we have and we have requested data from ODA about Medicaid, about expenditures in state-funded programs, about expenditures in the Older Americans Act to try to compile this and lay that against projected increases in older population and in persons with dementia to forecast some increases. If you're aware of any data that is available that does this specifically for Ohio, we certainly want to see that, and we are continuing. We did a fairly deep dive over the course of last week into a number of different data sources, as we will see through the course of the discussion today, but recognize that we have probably not even gotten close to capturing a majority of that data. And so if there are data sources that you are aware of, please point us in that direction. This one is certainly the one that is the most incomplete. So.
Thanks, Shonda. All right, so I'm going to start with Sally. If there's specific information around the fiscal impact on systems, people, policy providers, I'll ask you for your input. And Greg, I just saw your hand, so I'm going to ask Sally to finish and then we'll jump back. Sally, are you on mute? Okay, we'll come back to Sally. Greg, you had your hand up.
Yes, can you define what you mean by long-term care? Is that institutional care? Is it in-home care? Can you just be more, give us a little bit more detail on that?
Yeah, I think for purposes of this, I think we're going to go with long-term supports and services. I could pull out SB 24 and look at how it's defined there. I don't have that literally right in front of me, but as we're going through this, I can try to pull that out if that would be helpful.
I guess I would think of it as home and community-based as well as within facilities. So just think of home health services as well as think of some of the skilled nursing facilities, and then those in the middle, the assisted living facilities. So I would think of it that way. Just think of the whole suite of services. Okay.
I would concur, and all of the data that we have gathered, and including data that we get today, is looking at the spectrum of long-term services and supports that includes everything from personal care and home modifications all the way through nursing facility care, because people with dementia experience that spectrum, and we expect that spectrum as a whole to be impacted. So.
Maybe a better way of stating it might be formal versus informal supports. Formal being anything that is, kind of outside of the family, outside of the, that's coming from outside in some fashion.
Mm-hmm.
I mean, that's a commonly used distinction.
And it captures that whole suite as well.
Right, exactly.
All right, so
we have another issue that I'm grappling with. This is Doug Beach. I can't determine whether we're looking at this pre-pandemic or post-pandemic, because a lot of the home community-based services have been in a hold mode for much of the pandemic, and so what I would have told you pre-pandemic will be different than what I tell you now.
So what I would say to that is that that's the beauty of it, actually, if you have to say, because what it did was it just highlighted where the maybe strong points and where some of the fragilities were. So I think it just highlighted what we had. So I think if you look at it from that perspective. Okay. Go ahead, Leanne. Do you want to take us through?
Sure. Sally, are you back on?
If not,
okay, so I'm
let's
going to go
move.
to.
Yep, I'm here. I'm sorry. I was kicked off the. I got kicked off the call and had to rejoin. I apologize. So
It's okay. All right. So we were starting with you around this question of fiscal impact on publicly funded health programs. Again, sort of your observation, your experience. What do you know, and what conclusions do you draw?
That's a pretty broad question. So I may start with a fairly broad answer in that, I think what I've seen just in my experiences around the state is that, there are some things that there's just inconsistencies, from one community to the next in regards to what's available for individuals with dementia. And likewise, I think the funding is similar too. Funding is very, very different. And I think what Doug said about looking at post-pandemic, it's, I think, going to be really eye-opening. There's still a lot of adult day centers closed. Senior centers are just starting to open, and how things will shake out over the next 12 to 18 months. It's concerning to see what will be available. So. But and so that's I think just a real general when we think about home and community based and long-term care services is that there's some real great shining stars of examples of work being done in communities locally through organizations or I've been involved in a couple dementia friendly community initiatives that are being funded by ACL that are pretty exciting, but it's just I can go 2 counties over from where I live and there's nothing, and then there'll be something in one county to the next. So I don't know if I'm at my time, but
you're just at time. That's great. Thank you. It was about 1.5 minutes. That's great. Thank you. Thank you for that. Lisa Brockman.
Hi. Yeah, I echo those things, but of course, I think we have a lot of great things available, but there is no place for people to learn the difference between the various services available and how they may apply to their loved one's journey. And so I think that's the biggest challenge right now, is that if someone goes to a marketing person who tells them that their services can do this, they believe them because they don't know any better. And so there's not really any kind of consistency of regulation between the various levels of long-term services. To make sure that all of the same language is being used and that consumers are getting a good comparison of apples to apples. I think the other challenge is going to be reimbursement. We all go to local places, fast food and everything, who are all upping their daily rates for staff. But we are all reliant on Medicare and Medicaid reimbursement in the long-term care world, which is going to be slower to turn around to that, and reimbursement for our population specifically has always been lower due to them not sort of scoring as high in various aspects of need for care. So I think those are some big challenges we have had.
Thanks, Lisa. Catherine.
So I'll add on a little bit more color to Sally's comments, and what she noted about the varying resources of different communities, I think is reflective of what we're seeing in some of the not-for-profits, as they have been providing support for the local communities, and they're doing it without any fiscal support. They're doing it primarily through charitable contributions and fundraising and some grant support, as they seek to meet the needs of the community very specifically. And so that tremendous variation between community because of the resources, I think, reflects a challenge ahead. How do we arrive at a solution that brings a consistency across communities, regardless of economic ability and economic resources, to meet the needs of the individuals there?
Thanks, Catherine. Bonnie Berman. Hi, Bonnie.
Got it. Hi, everybody. I have just 4 quick points, and of course, interrupt me when I go over. When you talk about publicly funded, my biggest concern is whether we are talking about people who are diagnosed with dementia or people who are living with dementia. In our state, we estimate that, I've got to turn to Trey on this, but I'll just say the 40% really have a diagnosis. So the question is, what are we talking about? People living with or people who have been diagnosed with? Secondly, when we talk about public funding, what we know is that care partners have a much higher incidence and prevalence of diseases when they don't get the services that they need. And so I think that when we talk about publicly funded, we may want to talk about that part of the dyad as well, which gets me back to the slide you have on right now, where it says what is happening in Ohio relative to people living with dementia. I would like to respectfully suggest that we talk about people impacted by dementia instead of living with dementia, because what that does is it introduces the dyad. And secondly, it also talks about staffing, because they are really impacted in both in long-term services and supports as they care for and about people with dementia. The other thing I wanted to point out by talking about the per county, in the Science Committee meeting, we received a document from the Ohio Department of Health, and it was about the number of individuals per county, or was this part of it, who had died from or with a dementia. And it was astonishing, the differences between counties. And so what I want to do is reiterate what Catherine and Sally indicated, and that is it's very difficult in Ohio to talk about what's going on in our state when we have such disparities and disconnect in individual counties.
I'm going to stop you now if I can.
Yes, of course.
I got 3 of your 4, but thank you. Thank you for that. And hang on to that last piece of information. We want to make sure we get it at some point. We'll figure out how to capture things that we're not getting at the exact moment.
Thank you.
Just want to confirm that. Yes,
I'm sorry to constantly interrupt. I'm going to have to jump in a moment, but I do want to respond to this question, if I might, before I hop off. So when you ask about public funding, I guess my concern, I don't know if I'm bringing a solution here, but my observation is that it is very much geared toward later intervention and not early. And by that, I mean, you have to meet, and oftentimes, a particular level of care, or it requires such a decline before there is opportunity to intervene. And that, from my perspective, is an outdated model that we would benefit from evolving. And so when we talk about public funding, I think also we have not taken advantage of or looked at opportunities to really leverage public-private and to see when we do have public dollars, if they can be used sooner than we're allowed to oftentimes use them now. So I want to make sure that I got that in before I have to jump here in a moment. Thank you for allowing me that.
You're very welcome. Thank you, Director. Thanks for your time this morning. We appreciate you joining us. Thank you so much. Tina, you're next on my list. To be Tina, and then Diane and Pam.
Hi. I kind of go off what everyone else was saying, but I think one of the big things, and I might not be, this might be down the road that we're going to talk more about this, but the lack of services in the community, like everyone else said. Also the education for families and residents, and the style of education, like maybe more hands-on versus just internet reading or just reading slides, and also like staff and family reimbursement. And one of the things that I see with families here in long-term care is they go home, they utilize the internet, and they cannot navigate the system because everything they're trying to find there is difficult for them to navigate around or find what they're looking for. So I think if funds could be used towards an easier portal system for families and even like staff to kind of look into. Thank you.
Thank you very much. And Diane.
Hi. Unfortunately, well, fortunately, actually, I'm on the same bandwagon. One of the many things that comes up again and again is how Alzheimer's and related dementias impact women a great deal. The numbers show a high incidence of female patients and, of course, female caregivers. And the earlier the diagnosis, obviously, we all understand, the better off. However, because then those individuals can seek services. However, the ability to find those services quickly and easily within their communities is often impaired by their ability to search the internet, their ability to reach out within the community, and their caregivers, their immediate home family caregivers, who are usually at a loss. So all of those things put together bring home care back to a forefront for me. And family caregiving, how does one prepare and continue to develop their care at home for their loved one?
Thank you. I have Pam Reese, and then Joe and Melissa. Pam?
Hi, this is Pam. We don't have a true process for anticipation of need. And so a lot of the families, and in fact, I think there's almost 80% of the individuals with Alzheimer's or dementia are living at home or with their families. The families are ill prepared to determine early diagnosis and to have intervention immediately that will help guide them through the process with their loved one. Also, with the skilled nursing, even though during COVID, the 3-day stay in the hospital was waived, it's not easy for someone with Alzheimer's to access that service unless they have a condition that put them into the hospital for 3 days. And then also the memory cares and DLs are a lot of private pay. And although there's the waivers and there's some access to funds, this is a huge burden on families, is to pay for different resources and to be able to accommodate their loved ones when that time comes. And I have a lot more, but I thought I would keep it at that.
Thanks, Pam. I have Joe, and then Melissa and Leanne Smith. Joe Russell.
Hi there. Thank you so much. Really appreciate the conversation. I'll try to keep my comments brief, obviously. What's happening in long-term care in the community from our perspective is we're seeing that a lot of families and individuals afflicted with these diseases don't know what their options are. Once they kind of after the diagnosis period, when there's a realization that sets in that there's going to need to be supports, families kind of just start to say, okay, what now? And that creates a lot of confusion and, quite frankly, a lot of fear. What we're also seeing as a result of that is families are doing whatever they have to do to make ends meet, whether that is change careers or whether that is place somebody in a setting in which they can continue with their normal life, or just trying to make do. I've used examples in the past of what we've termed pop drops, where someone will drop their loved one off at a hospital just so they can get some sort of respite, simply because there's nowhere else to go. But what's working well, we're seeing an organic growth of programs at the ground level within communities. Our programs certainly have a fairly robust training program that they're putting their people through, just because there's so many people that are afflicted with this. We're also seeing the development of memory cafes and different localized programs that are kind of picking up some of the slack. So that's a good development. What conclusions have we been able to draw? Well, I think it's apparent to our members that there needs to be public awareness of support options. Families need a place to go to be able to get that more information and about their options, both in the diagnosis period, the risk factors, but also where do I go if I need supports? We think funding is very important, obviously, but we need to be careful that we're looking at funding and support for the providers of these programs and not just funding and supporting the programs. We see a tendency to
Joe,
want to fund
pardon me.
programs.
I'm gonna need to stop. Thank you. Pardon me for interrupting you. Thank you. Again, hold on to those thoughts. Make notes. If you don't get to say everything, we will absolutely capture that. We will ask you for that. So I have Melissa and Leanne, and then Jean. Melissa.
Thank you. Good morning. I had to join late, so I think I've caught on to what we're doing right now, and I'll try and be brief. With regards to what's happening in Ohio with long-term care relative to people living with dementia, as a prosecutor in my background, I see that there's need for improvement in required immediately reporting incidences to law enforcement rather than waiting hours for whatever reason. And then also some sort of increased background check, drug testing for employees. I realize that also comes with a funding cost, and I'd like to see followed implementation regarding males that work with female patients. I also, when we talk about the conclusions we draw from data, I'm blessed to live in Delaware County, where we are rich in resources, and we have a wonderful facility called SourcePoint. But I realize that is not the same across the state. But even with these resources, I see my own individuals and family members struggling to find information because they don't use the internet, or if they do use it, they don't use it properly, for lack of a better word. So yes, the internet is great, but we need to also focus on developing face-to-face contact with what I'm going to call our constituents to figure out what they need. Some of our local fire departments actually employ a social worker to do that. Now, if we talk about data, I would love to see the data that you guys are looking at, and it would probably help better direct my comment on this, but we can gather all the data we need, but we need to make sure that data is coming from our constituents who are going to be immediately impacted by this report when it is finished. And I don't know if people are connecting with others besides the task force members, but there are millions of people in Ohio that would benefit by giving their experience and opinions to this task force. Thank you.
Thank you. Thanks, Melissa. We will talk a little bit at the end. Director McElroy has asked us to facilitate several public forums, and we'll be talking a little bit more about those at the end. So thank you for that. Leanne and Jean, and then Pete.
Well, good morning. I was making my own notes as I was, contemplating what I wanted to say today. And so, I've had the benefit of everybody else's comments ahead of mine, which a lot of the same things I agree with and wanted to share. But I think that a couple things that stand out to me is for those that are caring for loved ones at home. I think that there is a need there to offer them some kind of financial support. They just want to keep their loved one home as long as they can. And so they're looking for those resources. That leads to another challenge of staffing and people that can go into their homes and help them and stay with their loved ones so they can still go to work or do things like that. So I see a huge need there, for those people that are dealing with that. I also think that emergent care that I believe Joe talked about is those people that need help right away. They can't wait for a 3-day stay. They can't wait for something. They need to know where they can go to get help right now, to get a break and get some care for their loved ones that is desperately needed. And then I think finally just again, considering what Sally said and a couple of people before me, that the difference between kind of the nonprofit facilities and the difference in the counties. I'm in a small county. I would love to see some type of personal liaison in each county in the state that maybe and there would need to be more than one, obviously, but just that face-to-face person that can help and get people to the resources they need.
Thanks, Leanne. Jean Thompson and then Pete.
Yes, thank you very much. I agree with many of the comments made up to this point as well, but I think I'm going to focus my comments, because it's my area of expertise, would be in the assisted living component of long-term services and supports. And I did have the opportunity to glance over the information that you sent this morning, and one thing I noticed was a very small number, for instance, compared to skilled care, of people utilizing assisted living in memory care situations. And I wanted to point out that I believe that is a reimbursement issue, that the waiver is reimbursed so lowly, $72.26 a day, that people cannot afford, nonprofit as well as for-profit, to care for people with significant dementia, which that's another air at that point with that kind of reimbursement. So I do think, at least in terms of serving people who've reached that point where maybe the wandering is so different reasons that could be that they require an in-place placement, then I think that assisted living could offer a lot more if we were realistic about a reimbursement for a memory secure unit. So that would be a conclusion I would draw on that. I do think that in addition to the comments about regions, etc., and I think it was alluded to, but since we're covering such a broad range of the illness from the very, very beginning stages all the way to where you really do need a placement, maybe, that we need to make our responses address those varying stages of the disease, or at least try to tie to those varying stages of the disease.
Thanks, Jean. I'm going to need to stop you there. Thank you.
I was stopping.
Oh, great. Great timing. All right. So I have Pete and then Trey and Doug.
Thank you, and I'll try to be quick. It's hard for me, as those of you that know me know. So, a couple things I agree with. I think it's going to be a very important focus of this group to look at how people get access to information, as several people have brought up. I think Jean is right on target that assisted living for people with dementia is a very, very important piece that is not well funded and is not well utilized today. And we're talking about people who can't afford to pay privately. Lastly, relative to the data, since this was really supposed to be focused on data and fiscal issues, I think it's a question for this group is, do we want to look at data of spending on services and availability of services kind of in the aggregate, like say long-term care or skilled nursing care as a specific example, or do we want to try to break it out and as to how much of that is going to people with dementia?
Thanks, Pete. Trey and then Doug.
Yes, thank you. And I'll be brief as well. I think everybody pretty much mentioned a lot of what I would say. I think two things though, as it related to consistency, I think consistency comes especially in lieu of staffing and really looking at, memory care and long-term care, licensure, training, especially of direct care workers, et cetera. I think we haven't seen at the association a level of consistency there among the long-term care services and support spectrum. And what happens is on the consumer side, where the caregiver is at, they're not seeing the consistency with their loved one. And there's this, we see movement of people going to different facilities. We noticed that significantly during COVID. We're seeing that now post-COVID to some degree. And I think the other thing is really care coordination, especially through Medicaid, and looking at reimbursements and saying, look, ultimately, we want to have all of these services and we want to have all of these supports, but reimbursements obviously have to be adjusted to accommodate that, even as it relates to training. We can't expect, I think that it's harder to expect, and we've pushed as much as we can around memory care licensure and training and things of that nature. But it's a challenge for those that are in the space. So I think that's something that we've seen just has not been consistent, that we'll need to get consistent as the state continues to age and obviously dementia continues to grow.
Thanks, Trey. So we're going to go to Doug and then Representative Creech and Representative House. Doug.
Yeah, just a quick update. The Aging Disability Resource Network, which is coordinated by the Ohio Department of Aging, started out as a federal Older Americans Act initiative, has done a very good job from my perspective during the pandemic and getting people vaccinated and getting all that information out. So that's generally the first place that people may want to start. Those are run by area agencies on aging and SILs. One of the things that's been dramatically different for me here than when I lived in Florida is there aren't many adult day centers around in Ohio. The Alzheimer's Disease Initiative in Florida was heavily tied to adult day and is heavily tied to PACE. We may want to look at that. And then last thing, from a funding perspective, certainly we have Medicaid, we have Medicare, we have the Older Americans Act, but we have a substantial program throughout Ohio where there's a lot of levies, and I think it's 67 of the 88 counties has levies. Melissa referred to the one in Delaware County, which is at the top of the heap. But it'd be interesting to see how those levies work in the Alzheimer's space. I don't know that there's anybody on the call that comes from that space.
Thanks, Doug. I have Representative Creech, Representative House, and Senator Wilson next. Representative Creech. Not really. Let me try that again. Looks like you're muted. There we go. No. Representative Creech, if you're speaking, we can't hear you. Okay, I'm going to loop back around. I'm going to go to Representative House.
Hi, good morning, everyone. So listening to the conversation, a lot have been said, but I would just say from the perspective that I sit from, the state of Ohio does not do a good job of collecting data. We have to do a better job to collect information so that we can be more proactive in making sure that we are investing in the interest. The other thing is, I don't even think we also don't invest enough in just supporting people, right? Caregivers who are doing the work. And that's really a viewpoint that I look at, is because it's a benefit that we have caregivers that are working, but it's also a disservice that we're doing to ourselves because we do not invest in people. You know what I'm saying? And I think I have so much to say, but I'll stop there. Those are my two things. I'm just going to say the data and the investment. I'm specifically talking about on a legislative front. Legislators, we talk about, aging, we talk about, Alzheimer's, dementia-related care. But when you look at the way, the lack of the financial investment that we as state legislators put into it, comparatively to the size of the population and the amount of money that we are working with, it really is, it's pretty sad. So I really hope that through this process, we can give some very clear direction to legislators on how much you need to be investing. Even if we can't do it immediately, I think we need to be explicitly clear of where we need to be so that we can actually start holding people accountable to make those investments. Thank you.
Thank you very much. Senator Wilson? Senator Wilson, if you are sharing, you're on mute. We can't hear you. Okay, he may have had to drop off. I'm going to go back for a moment to Representative Creech. Are you able to join us?
Can you hear me now? Can you hear me?
Yes.
Okay, my mute button was not working, so I apologize for that. But no, I again, I hate to keep repeating myself, but just listening and learning, I think this has been great today. And, I agree with Representative House. I don't have a lot of experience with the state at this time. I'm 6 months in, but I think collecting this data now is going to be great for us to make future decisions, and looking forward to seeing what we come up with.
Thank you. Did I miss anyone? There are a couple of folks joining by phone, so I don't have names next to those. And I know that Kate from Senator Yuko's office is here taking notes for the senator.
This is Lori Seebeck-Russ, and I'm joining by phone. So
hi, Lori. Thank you. Sorry for skipping over you.
No, that's okay. I just have a couple quick comments, and I think everybody has sort of summarized the essence of my thoughts as well. But I think we're really looking at the need for a roadmap, a more clear, consistent roadmap. I come from the healthcare side, and I think we have to do a much better job upstream. So, we have folks in our healthcare system that are not making the diagnosis they need to be, or making a diagnosis and then leaving the families kind of with a diagnosis hanging and no clear plan going forward. I know on the healthcare side, there's often a huge struggle with how to manage people with comorbid dementia. So it's, how are we taking care of people with heart disease who also have dementia on the inpatient side? And then what are we doing for the families in terms of the pull-through process upon discharge? And then the other piece I was just going to add, which I think is piggybacking on what Doug mentioned, which is there was a pre-COVID and then there's the post-COVID. And a lot of the families that I work with were having a lot of psychological struggle. I mean, the biggest struggle is always about decisions for getting more support, getting in-family help, out of the family help, and then also decisions for placement. And then post-COVID, I think families now have figured out that they were able to Band-Aid solutions, and now they're looking at, do we even need placement? So I think that whole issue around times when people are really needing to place their loved ones, COVID put a huge wrinkle, and families lost a lot of confidence in that process. So I think we have to do some work around that. And my final piece is to add that I'm happy that equity and the disparity of care is being addressed across the board, because we definitely see the need for changes there.
Thank you, Lori. And Greg, I see your hand up. I think I skipped over you on my list, so please go ahead. Thank you. I apologize.
Yeah, no problem.
So sorry.
So
you turned your camera
worries.
off and I lost you.
No worries. We're a private pay assisted living operator that specializes in dementia care, and we are unfortunately constantly turning away Medicaid potential residents. And the problem there is I would love to have some Medicaid beds in my community, but I can't afford to have them there. We can't afford to provide them with the proper services, the dietary needs, the things that we do here that I know are super beneficial for somebody that's dealing with dementia. So obviously the public funding is a big thing for me, and if we can get that straightened out, I think that more private operators would be willing to bring the Medicaid beds into their building. And then secondly, I think upstream, as Lori was mentioning, that if we focused on healthcare insurance companies, that they are totally into healthcare screening and proactive healthcare measures. None of those have anything to do with cognitive screening. And I would think that if we could get something in place that if you're going to be a healthcare insurance provider in the state of Ohio, part of what you will help to fund is pre-screening on cognition. And so I think those two things, if we could work on that, and I think that's low-hanging fruit with the health insurance companies to really add that to as often as you get a physical, you get a cognitive checkup. Mm-hmm. Those are the two things that I'd love to hit on. Thank you.
Thanks, Greg. Well done. Well done. We are through our first question. Let me ask really quickly if there's anything that you were expecting to hear regarding specifically the financial piece that nobody said that you want to make sure you add. And then Yonda or Debbie or Christy, any data questions that you have relative to what you heard, that either data you think we have that conflicts, or yes, we have this data and we've already talked a little bit about where we can get some additional data. So let me ask first, anybody not hear something that they wanted to hear? Pete.
Yeah, I just want to throw in something real quick, keying off of what Trey had to say. We have to look at what people are getting paid to deliver these services, and the impact on being able to get them and being able to get people who are appropriately qualified.
Thank you. Yonda?
Yes, so we did send you a packet of data, but let me tell you a little bit about sort of process, because again, we're moving really quickly, and our intent in this first go round of data review was to find pieces of data that spoke to the different elements in the legislation, especially once we started to sort that into buckets. There is a lot of information out there. It's not clear. I think we're still figuring out where the gaps are. And I think we are seeing areas where the information is incomplete, but it's also quite clear that we are probably missing information sources. So one of the things that we would continue to ask you, so for instance, the area that we have not yet really explored data-wise is equity. And sure that we are looking at equity, and I think that I'm aware of a couple of sources, but I would ask you as a group that if you know of data sources that can speak to the issues of equity, and I see Trey's hand up, I hope he's putting a hand up to point to some sources. We certainly need that information. I think that, then if you'll hold just a moment, Trey. So as I listen to the conversation that has just happened, I'm not hearing anything that surprises me. I do hear some things that we don't actually have a great deal of data on. I think we're working on gathering the data around reimbursement, projecting fiscal impact, and can hopefully be able to do some correlation to costs. We have some data on the county levies, and that data certainly is illustrative of the varying levels, the inconsistency of resources county to county that was spoken of. I think it's also important to note, though, that at a macro level, that program is brings resources into Ohio that many other states don't have. So in the aggregate, that's a real strength of the Ohio system, but the inconsistency potentially makes it, something that needs to be addressed. On workforce, we shared some workforce data that we gathered. This piece is incomplete. There is a massive amount of information available nationally on workforce challenges in the direct care workforce. We are trying, though, to make sure that we are looking at Ohio data, and that is a gap. I see a question from the chat. We did, and somebody is asking, where is the data? And we sent data packets out about 7:30 this morning. And hopefully by next week, for next week's discussion, you'll get data packets earlier. But to come back to, workforce is a place where there is a gap in our data, specifically around the experience of the workforce shortage in Ohio. We don't necessarily, I'm seeing resources here. We don't necessarily disbelieve that there's a workforce shortage. I don't think anybody would disbelieve that there's a workforce shortage, but it's really important to be able to quantify that shortage, to identify what may be geographic variabilities or inconsistencies. Are there certain segments? What's driving that in Ohio, to be able to finalize findings for the report, or to develop a finding that says we need more data in this area. To Representative House's point. The other place where there is a similar data gap that we seem to be relying on heavily anecdotal information is around the need for people to have consistent access to high quality resources and information upon diagnosis. There is a lot of anecdotal evidence that supports that. But in my initial pass through research, it was hard to find anything data-wise that supported that. Again, a finding may be here that we need to collect data, but we don't want the collection of data to necessarily stand in the way of potentially moving forward in the recommendations with the need to stand up systems that allow for that. So I would say that I'm seeing a lot of things happening in the chat. So I'm going to stop here so that we can, perhaps take a look at that. But that is sort of what we presented to you and sort of my recap, just based on the discussion that we have heard so far. So I don't know, questions, comments, or Leanne, are you ready to go back to the next questions?
Well, let's see, there's, I have to move between here to see who has their hand up. Looks like Trey. So Trey, you've got your hand raised, and then Bonnie has her hand raised. So why don't we do Trey and then Bonnie, and then what we might do is take a quick break because we've been sitting for a little while, and we'll come back to our second question. So Trey, Bonnie.
Yep. The only thing I would note just on the equity piece is we did a Facts and Figures 2021 report. It was more macro in nature, meaning that it was pretty much all across the country was the scope of the data. However, one of the things that we did mention or did notice is around the equity issue, early detection and screening was kind of the major problem, and really the lack of access. I think it's kind of come up here prior to in previous discussion and even in this discussion, but the ability for folks to access proper screenings throughout their journey has been a problem. A lot of that typically falls on a primary care physician of some sort. And the states that have moved in the direction of kind of getting ahead of it as opposed to behind it, similar to what the director said, have been quite successful, not only in reducing cost overall as a state, but also getting ahead of it in communities of diverse communities, specifically Hispanic Latino communities. I know Florida's done a lot of work there, as well as their African American community. So we have a more macro sense of the data around the really early detection and screening, which is more preventative in nature, but also it sets all the other systems up to know what we're looking at. But also for states that are looking for this type of data, that is the baseline. If we're requiring or codifying folks to do that on the front end, we'll collect the good data from Ohio at least to be able to steer the direction as a state. We've seen that again, Florida, Wisconsin, and Massachusetts, I think, and a couple other states that are kind of reversing the model to some degree, and Georgia as well. Excuse me.
Thanks, Trey.
Yep.
And Bonnie, last comment?
Yes, I just wanted to respond to something Yonda said about, what data sources don't we have, and to piggyback on what Sally Boland said very early on, is that we're talking about home care and we're talking about more care in care communities. But the question is what goes on within the community itself. And Sally brought up many of the dementia-friendly initiatives that are going on around our state. And we haven't talked about any of the data that exists with them in communities. So thank you.
Thanks, Bonnie. All right, I don't see any other hands at the moment. So here's what I'm going to suggest. We had a 10:20 break on our agenda. It's a few minutes before that, but we're not going to get through a whole lot more in 4 minutes. So I'm going to suggest that we take a 5-minute break. I'm looking at a clock that says 10:16 on my computer, so we'll come back at 10:21 and start on our next topic. I think we'll probably get through that next one, and that will be it. So if you want, turn your camera off, turn your microphone off, stretch, and we'll see you in 5 minutes. Okay, I'm going to go ahead and get us started. Let's see. I can only see a couple of folks on screen, so let me see who's back. Okay, I can see Yanda. And here we go, folks are coming back. Great. Welcome back, everybody. Okay, hope the break was helpful. It was, at least for me, just a moment to stand up and stretch a bit sometimes is a good thing. Oops, I stopped sharing, so let me go back to sharing my screen here. And I believe it's this one. There we go. Okay. And okay, sorry, I'm just dealing with a little technical. There we go. Okay, now I can see everybody again. Recognizing that we're using the language long-term care, taken from SB 24. I actually think I'm sort of making a mental note that we will try to add some time in, probably be our third meeting. I think by the time we can get to it, but just a bit of a conversation around best practices language and making sure that we're aligned with what you want us to use. I spend a lot of time in the plain language, best practices language space. So we want to make sure that we're getting that right. The next topic are the topics in SB 24 that were captured in section B1 or bullets, section B bullets 1 through 7, and then section C bullets 8 through 10. And those topics are the existing resources. It's a pretty broad topic, existing resources, including cost and availability, and SB 24 specifically calls out care services, dementia-specific training and quality measures, and more specifically calls out residential care facilities and HCBS. There's also a bullet about the adequacy and appropriateness of geriatric psychiatric units. And we actually have a question for you about those. That sort of shows up at the end. So I'm gonna, you are welcome to speak to that. We just know that we have a couple of questions about that. And then the language and the request around policies and strategies, again, pretty broad language. Improve services provided in the home, improve long-term care, included assisted living, that's probably the most broad, and assist unpaid caregivers. And so this is going to be our next topic. Because this is a little more detailed than the first one, I'm going to leave this slide up if that's okay. Just a reminder that we're talking about things that are going well and or places we could improve and what conclusions might you draw. And in this case, I'll give you the roster. We're going to start with, I'm going to sort of, if you were in alphabetical order, I'm going to start near the bottom and then go to the top and then kind of work my way back to the middle a bit. So I'm going to start with Leanne Smith, and then we'll go to Trey and then Lori. So can I start with Leanne?
Okay, so I guess is your question, you're asking, I'm just reading this and I've read this before, but your focus on this question is for the the dementia specific training and quality measures. Is that what we're?
It's really anything related there under B1 through 7 and C 8 through 10. It really is both. Yeah.
Well, I think I in our capacity committee had mentioned, many times that I think the dementia specific training is just a huge piece of the care for in all facilities, assisted living, long-term care, adult day. I feel there needs to be, and I know there are some in place in some facilities, and that's fantastic, but I feel like there needs to be more hands-on specific training. And I think someone had mentioned it in our last little question about, maybe it just not being something that they're reading, the staff that are working in these units or working in these facilities or doing home care services, that they have more of a hands-on training to understand how to deal with people who are struggling through these dementias and Alzheimer's. Learning how to redirect, learning, just different avenues of how to handle these people. I just feel like that, to me, is a huge piece that needs to be thought of and addressed, and hopefully at some point put in practice.
And Leanne, anything more around that? Is that also tied to policies and strategies, do you think? Do you want to add anything more specific around policies and strategies?
Well, I think that, one kind of probably goes along with the other. If, yes, definitely there's, ways to put those into a policy. And, again, I know that facilities have a lot on their plates now, but having the proper policies in place for training for these specific programs, to me, is going to, just as your bullet point says, it's going to improve the care that they're getting in long-term care and assisted living facilities. And your last bullet point for assisting unpaid caregivers, I think that is also just a huge need, because there are a lot of people out there who are caregivers and are struggling. Maybe they can't go to work anymore. They're staying home, trying to keep their loved one there, or, just, whatever that time may be that they have to put into that. They just assisting them in that level, I think at some point is very important.
Thank you. And I failed to mention that we have about 2.5 minutes each. That gives us almost an hour, actually, to get through this conversation. Thanks, Leanne. So I'm going to go to Trey.
Yep, thank you. I think that just from a fiscal impact on publicly funded healthcare programs, I think ultimately the other two areas, in my opinion, kind of are predicated off of that, and especially as it relates to existing resources, cost availability. And one of the things that I would say, just in looking at where the care services, dementia-specific training, and quality measures are not at in Ohio, we need to really double down on those and on that issue, because I think it complements the fiscal impact from publicly funded healthcare programs, programmatic standpoint, because we really don't have a baseline in services and training specific in Ohio, at least. We don't really have a baseline. I mean, I think it's one of those things. This is probably the greatest area of the task force to really establish just simple licensure and dementia-related training for direct care workers in Ohio. I think that's the one thing that we hear in our data feedback from real people that are caregivers, folks that are afraid to enter into certain area. I mean, enter into certain communities in the long-term care spectrum, because there's unknowns, and it's not a matter of the system. I think the systems are good entities. I think it's the staffing, and the staffing level and of training for people that are working with someone with dementia is night and day different than folks that are not. And we have to acknowledge that and double down on it and spend the resources to get staff adequately trained. I think the opportunities as well, just going into policies and strategies a little bit. Obviously, I think Project Echo in the long-term care sense is something that can be rolled out. We've seen states do that and have success at that. I think also looking at the overall infrastructure in the state as it relates to just going back to just before folks enter into a long-term care service and support scenario, is where's our infrastructure at, and how do we build it in a systematic way to support long-term care services, but also complement that through just simple education on the caregiver side, as well as on the patient side as best we can. I think that's the thing that unpaid caregivers a lot of times just need to know where their support systems lie, as well as where they can go to get additional support if their loved one is entering into a long-term care service support setting. We provide some of that, but the reality is there is so many caregivers and so many people, we cannot get to scale as the Alzheimer Association and others that have spoke up already. It's just hard to get to scale. And the numbers are continuing to increase So the more we can provide that level of support and public awareness, the better off we'll all be long term.
Great timing. Thanks, Trey. We appreciate that. All right, Lori Stevick-Rust. Are you still with us?
Thank you.
Great.
Yes. Can you hear me okay?
Yes.
Okay. Yes. Coming at it through the lens of a dementia trainer, and I've been doing dementia training across the country, so I know what other states are looking for and what their requirements are. And then also, consulting on the global level of what places outside of the United States are looking at. And so I think when I distill all of that down, the bottom line comes to what we've been talking about on the science committee is training has to be tied to the science. It can't be tied to intuition or what people think, because I think that's where we get into trouble with not providing the right kind of care to our most vulnerable seniors. And so I think consistency, policies and procedures within hospitals, within post-acute care facilities that understand the importance of only allowing staff who've been adequately trained to have contact with the residents. One of the things that I think is the loophole that we struggle with here in Ohio is training is not consistent. Training is not always enforced. And then, part of the way that we get through that loophole is by using agency. So it doesn't help serve anybody's needs by having agency who's never worked in dementia care units to be allowed to staff a dementia care unit. And so I feel really strongly about we're doing a great disservice, and it's not just about, okay, so they don't really completely understand the care struggles for people who have dementia and the vulnerability. We're not treating them as medically as vulnerable as they really are. And so just because dementia care facilities fit within assisted living housing, we sometimes think about that more socially as opposed to even medically complex, vulnerable people. And the staffing training should match that. That's number one. And I think the other thing I'll just add is you made note about geropsych units. And I think that is a very complex issue that absolutely needs to be addressed. Yeah. I don't think we can say that they're either good or bad or needed or not needed, but I think they're overused. When a facility takes on care of people with later stage dementia and they can't understand how to manage behavior or medication or mood changes, and they think about dementia only as a cognitive issue, they've done a great disservice to the family who entrusted their loved one to that community. Yeah. The need to pull the trigger on admissions to a geropsych unit often happens with any type of behavior or mood instability, which is part and parcel of Alzheimer's disease. And so if you're trained well and you understand that, you should be able to have systems in place to manage that. But geropsych isn't the punishing place that you remove residents as the family see that. So I think
I'm going to need to stop you, Lori. I'm sorry.
Okay, I'm sorry.
No, that's all right. This is everybody's passionate about this. Please don't apologize. I'm sorry I have to interrupt you all. Thank you very much.
Thank you.
Doug. It'll be Doug and then Jean and then Sally.
Trying to get off mute. Couple things. First of all, we have very limited dollars that flow from the Ohio Department of Aging through area agencies on aging to the Alzheimer's Association, mostly for training and education. Very limited. They do a great job with those dollars. Included in that package is supposed to be respite funds. And I'll tell you, the respite funds are next to nothing. We can't do any in-facility respite, can't look at adult day as an option, can't even look at senior centers as an option because those funds are just limited. The other thing I want to talk a little bit about, I'm on the board of directors of a local medical college. My son's a fifth-year surgical resident, and neither one of the trainings did anybody have an Alzheimer's or a dementia training. And my mother-in-law, a doctor, when she was in the hospital, doctor 20 feet away looked at her and claimed that she had dementia. And she did have limited dementia, but she also had advanced colon cancer, which he didn't care to diagnose. He just yelled across the state that she had across the space that she had dementia. So I think that we're not doing a very good job with our doctors. And by the way, Pete, You're supposed to offer food to everybody else when you're having it. You know how that works.
That's right. That's right.
The beauty of virtual, man.
Yeah. So those are two areas that have been a passion for mine for a while.
Oops, sorry, I muted myself. Thanks, Doug. Jean Thompson.
Thank you, Leanne. Well, just looking at this slide, I want to point out, and I'm not sure why it's separated, but it was something I wanted to mention anyhow. Residential care facilities are a home and community-based service. Those aren't separate things. As Director McElroy said at the start of this program, assisted living, it's tough because we don't fit exactly into any bucket. We're in the middle. I believe that's how she referred to it at the start of today. So it is a little hard there. But in terms of dementia-specific training, I guess one thing I'd like to stress is how intense that workforce shortage is right now. So it's my belief, and in our subcommittee, we did discuss it. I don't know that everyone agreed, but a mentoring kind of training, which happens over time on the job, is probably the best. First of all, I think it's best for the person learning, but it's also best because in this time of incredible workforce shortage, if you require it all at the outset, people leave you before they even get to actually utilizing it. So I just wanted to mention that. Geriatric psych units, I think building on the comments of my two predecessors, I think we have so few physicians moving into geriatric areas right now that it's a huge problem. And that, I guess, I don't know how the state supports and directs to that, but it would be wonderful, not just in geri psych, but in so many geriatric areas if we had more skilled medical professionals. On policies and strategies, I mean, I think that people have spoken at length today about ways to delay and decrease going to a facility, and I support that concept. The improving long-term care, including assisted living. I wanted to just point out one thing that I'm not sure everyone on the committee understands. The vast majority of assisted living, and your statistics sent early this morning bear that out, is private pay. So we are a different entity in that almost all the other services we're talking about are granted through Medicare or Medicaid programs, as was also said before. And I'm 100% on assisting unpaid caregivers. Our subcommittee talked at length about the need for respite programs, ones that would even allow people to stay in communities, Doug, that could be the biggest respite, getting 2 weeks when you could just go and, I guess, I don't want to say be free, that makes it sound, but not have the responsibility. So those are my comments, Leanne.
Thanks, Jean. I appreciate that. And I think Sally, I know, needed to step out, she said, for a meeting. So let me just check and see if Sally's here. Sally Boland? Okay, so we'll loop back to Sally. So Melissa, and then Pete and Catherine. Melissa.
Thank you. I'll defer my time to what everyone has already said and allow someone else additional minutes. I too will have to step out around 11:30, but I thank you for allowing me to be involved.
Thanks, Melissa. Pete, and then Catherine, and then we'll go to Lisa.
Thank you, and thank you, Melissa, for that. I was a little nervous following the prosecutor there, but no, just teasing. So I think, looking at this whole package of stuff that's sitting here on this slide, I just can't help but go back to funding, and it's just so important. And when we're talking about, training, training requirements or improving training, I think everybody would agree that, yeah, we should have people who know what they're doing, taking care of people with dementia. To Jean's point, we need to start with people. We have an incredible staffing shortage at the present time. I heard the comments earlier about we don't really have good data on that. And that is true. We're looking at doing some surveying of our members to try to identify that or quantify that a little bit. But we do hear a lot about it anecdotally. And funding is the starting point for both things like staffing, numbers, and in terms of staffing competency or training. You can't do it on the kind of reimbursement that is being provided at the present time. It just isn't possible. And not when you've got Cedar Point paying $20 an hour, not when you've got Walmart paying 15. Every other place is jacking up the wages, and so we in long-term care, long-term services and supports have to compete with all of that, and that's, to me, the fundamental issue that we have right now is staffing these services, whatever it is, and it's across the board. It doesn't matter what kind of service you name. They all have a similar funding problem and a similar staffing problem.
Thanks, Pete. Catherine and Lisa, and then Bonnie. Catherine.
Well, here to that, and I could spend all my time just emphasizing the points that Pete just made. But let me move on to a different topic, and it sort of is back to Trey's comments. And Trey, I could just listen to you all day, your experience and the breadth of knowledge that you bring. But one of the things I get a little concerned about when I think about creating policies around training is making sure that those policies are sufficiently robust, or that's not quite the right word, but that they allow for what we're learning in terms of how better to care and provide services for those with dementia. So new methods, new approaches that are, without any sort of boundaries, that are providing care in an institutional setting without any sort of boundaries that provide, that offer and must offer much more training for staff. Can we have policies that allow us to really be moving with new research and new outcomes, so that we're really making sure that the training that we're providing is as current and cutting edge as possible? I just hate for us to be too stagnant in that training.
Right. Thanks, Catherine. Lisa, and then Bonnie and Joe.
Yeah, I mean, I of course echo everyone has said. I think it does stem back, though, to the consistency of the training across the various levels. I think that because there is such a giant need for this population, it has resulted in multiple industries and multiple sort of, entities popping up, all competing against each other for the same staff, for the same, for the same clients, patients, individuals. And so, the whole sort of system is sort of cyclical, and trying to figure out how we get it so it's more streamlined, I think, regarding the training and the reimbursement would all be helpful.
Thanks, Lisa. Bonnie and Joe.
Yes, thank you. I'd just like to tie up with hopefully a nice bow what Catherine and Pete said, and that when we talk about fiscal impact, to me, it's very important that we do not separate out the monies and what we do with the monies. And I think the most important thing is what I think Catherine was getting at, is that we work to change the frame of how we see dementia and how we view care and caring. And if we just talk about increased funding without doing that, we would, I believe, be very remiss. So thank you.
Thanks, Bonnie. So we have Joe, and then Representative Creech and Pam. Joe Russell.
Yes, thank you. Thank you so much. So as I kind of alluded to before, there is a lot of training happening in home care regarding Alzheimer's and dementia related training. In fact, I think you'll be hard pressed to find a single program that doesn't have some sort of training that they do with their staff. The major issue is that training is wildly inconsistent across programs and across the state. Some of these programs might focus more on patient management, while other training might focus more on quality or care management. It just depends. And I think where my concern primarily lies is when you get programs who start to kind of set themselves aside as a specialist in this area, because there's no adjudicator of that specialist. That is to say that there's nobody who's determining whether they are actually qualified to call themselves a specialist or not. And I think that's problematic. But I also think we have to be careful about any mandates that we would create, because some programs, they might specialize in pediatric care, which obviously this doesn't apply as much to. So we want to be careful about how we do it. But in terms of a policy, I definitely think that there needs to be some consistent guide for agencies and how they're trained. And the last thing I'll say is just to echo some of the things that were previously said, and especially with what Pete said is, when you look at the slide, I think it's in slide number 30, that shows that there in the next 10 years, there's going to need to be over 250,000 job openings that are going to take place in home care. At the current reimbursement rates and with what we're able to pay, it's not possible to meet the need. It's actually impossible to meet the need. And so we really have to look at funding. We really have to look at wages, and we have to, and I think training can be a big part of that as well. So thank you so much for the time.
Thank you. So we have Representative Creech, and then Pam, and then Greg. And I was just going to pull up slide 30 really quickly so we know what slide you are referencing. And it was this, this slide here, the direct care worker projected job openings. Representative Creech. And are you on mute? I might have had to drop off the call. Okay, I'll try to come back. Pam and then Greg.
Yes, hi, thank you. This is Pam. I just, in regards to the long-term care, skilled nursing, and we're doing a lot of talking about the trainings. I know that the majority are doing it for compliance and they're trying to get by. We have some very good long-term care facilities and healthcare providers that do an extraordinary job of training. But a lot of them are doing training via video with staff sitting in a room, and then it's their signature on a sheet of paper that indicates they had it. And then they go out and they try to abide by basic care needs. And I just feel that perhaps there should be a more stringent and more detailed program or policy that requires the staff to be evaluated on that training. And unfortunately, they're mandatory evaluations, 90 days, yearly. It's always based off of, or perhaps not in every building, but a lot, or in healthcare providers, on general objectives. And the Alzheimer's and dementia trainings are not often revisited, and staff are often not observed for the care and services that they're delivering in regards to that type of training needed. Another aspect is in regards to the quality measures. For the skilled nursing, there's really only one that deals with antipsychotics, and there's not a true measurement of the care that they're delivering or to the Alzheimer's or related dementia. And I know there's not in a memory care or in AL. Another aspect of this is the involvement of families with the providers, and more support groups, more community outreach. And it's just, at this time, it's very hard for the providers because of the staffing. They're all in a crisis right now. And they're feeling good if they could just get someone hired today to start on the floor tomorrow, and then training is put to the wayside. And so I don't know how we fix that, but I think moving forward in asking for a more comprehensive training, something that's sustainable over time for the staff. And they go through such a turnover that they're constantly reiterating this type of training. And so then eventually it's not sticking. Again, I don't know how we correct that. In regards to the home care and hospice care, more for the home care. A lot of the certified aides or uncertified aides that are going to the homes, albeit are trained in dementia care, they're not certified nurse aides. And so when it comes to a certain stage of Alzheimer's where the individual needs two-person assist or requires a higher level of care, they're not receiving that service from those aides because they're uncertified and they're therefore more of a support system. And I know that from my own experience. It's very difficult to get the help at home that you need from those resources at times. And again, I'm sure there are some that do exceptionally well. The unpaid caregivers at home, and it would be fabulous if we could think of a way to help the families out. It's a huge expense to take care of a loved one at home. And then I think someone mentioned earlier about people are quitting their jobs or going to part-time. A lot of times they're just outright quitting their job and trying to make life work with their loved one with Alzheimer's or dementia. And as we know, as they progress through the stages, their care becomes quite more complicated. And then if you throw on behaviors and things like that that are disruptive, the families are in chaos a lot of the time. And then
I'm going to need to interrupt you. I'm sorry. I'm going to need to move on.
All right. Thank you.
Thank you. Craig, and then Tina and Representative House. Great.
Yeah, I'll just hit on it again from a private operator perspective. So I often tell people if there's a such thing as overtraining, we do that, but there's no such thing as overtraining in our industry. Now, there are some criteria that are set for if you're a licensed assisted living as to how much training needs to be given to different levels within the organization. So there are those things in place. Could it be increased? I'm sure it can, but for me, this is about culture and leadership. And I think there are many poor leaders within our industry, and they lack the skill set to lead properly, to set culture, and training is a culture thing. And I think that we need to focus on what is the importance of culture. How do you develop and then carry out a culture that has an emphasis on training? And so for me, those are a couple of things that we really focus on. We have our own leadership academy, and we are constantly training in-house staff that are future leaders of not even Kemper House, but also our industry. And so I think that, just focusing on at the care level is one thing, but also focusing on leadership. What is the importance of culture? And then just having sort of a methodology in place as to what is training to us as an organization. And then, the government can only do so much in private sector, for sure. So I think we just need to really put the tools out there that allow us to train in leadership, train in culture, train at caregiver level. And then also going back to the geropsych, I think there needs to be a symbiotic relationship between providers like us and the geropsych organizations. And what we do is anytime we send a resident to a geropsych, there's an absolute plan in place for us to get them back. A lot of times what communities like ours do is they dump behaviors on geropsych and then just let it go. We're done with it. It's up to you. And so I think it's important to actually educate communities like ours to actually work with the geropsych community and be able to put a plan in place that just says, hey, these are the 4 or 5 things we need to accomplish, and we'll bring that resident back under our care. I see that as a real disconnect. And I know geropsychs are very gun shy in that approach just because they're not used to it, but it's been working really well for us. And that's about it.
Thanks, Greg. Tina, Representative House, and then Diane.
Hello. I'm going to go on to the same type of topic as everyone else, the training. What I've noticed is, you know, when we send these residents that are working long-term care, that a lot of times the hospitals will place them in restraint. But really, I think it's a lack of understanding on, you know, the resident doesn't know where he's at or she's at, new environment. And I think it's just a lack of understanding. So, you know, we send these residents out that have dementia, and then I'll read the paperwork, and here they were in restraints for 2 days because they didn't know how to handle them or talk to them properly or appropriate interactions. And that does break my heart because, you know, deep down, you know, they're just scared. And so I think a lot of hands-on training for communication, how to interact with them, not only through hospital staff, but also transportation workers when they take the residents from our facility to the hospital or appointments. A lot of times they're scared because these folks don't know how to interact with these residents, as well as physicians, you know, talking about the driver's license, the staging of cognition. I also think that, you know, it's really important to have a good carryover. So if we do focus on training for all these areas of facilities or workers, that we all focus on the right things so the carryover can be continuous through all the facilities, all the workers, all the types of group activities that we have out there. And then, you know, I think it's really important too. I've noticed the hands-on training when I did a lot of my occupational therapy sessions with the staff on our dementia floor, and I noticed it when I started coming up on the unit and saw them bringing the residents down to the calming room. I think it's really important to have these calming techniques out to help decrease anxiety for these residents. I saw them implement, like doing activities, understanding stages of dementia so that the communication was appropriate during care, ADLs, all that kind of stuff. So I really do think that hitting on different areas of training is really, really important in different styles so that everyone has a better understanding because we all learn in different methods. Thank you.
Thanks, Tina. Representative House, Diane, and then Senator Wilson and Beverly. Hi, Beverly, welcome. So we'll start with Representative House.
Hi, good. So just in chiming in very briefly to the conversation around training, I think we have to broaden our thoughts of even how we are going to deliver this training. I think about how do we utilize just our just children, like even you thought about high school, like because we're all going to be retired hopefully at one age, and if we made it a part of like life, I think people would be better equipped, you know, to deal with aging as it happens, because inevitably, you know, statistically, you're going to have to address it. I also think about people that are retired themselves, and are there opportunities to utilize, I would say, the different use of their time to really help in this capacity. You know what I'm saying? I think it's just really, if we think about some really, how are we utilizing the time that we have, that people have available time, but we don't necessarily have to pay them in the traditional way because they're available, if that makes sense. And I'm not talking about exploitation. Let me be very, 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 very clear. I'm not talking about exploitation. I'm actually talking about, for our, K through 12 students, about really looking at project-based learning that really started to plant seeds very early on and putting them on a pathway to thinking about life and retirement and being good citizens and all that good stuff. And then on the inside, for those who are retired in the traditional sense, is there a way for us to utilize them in the communities that they live in for people who are living also in their communities that could benefit from their service if we partner people up? But that really would take a lot of community effort to kind of design things out, try some things, have some successes, have some failures, things of that nature. And then it was a lot of people said a lot of stuff about the current system we have, which I just don't think is working. But that's it. Thank you.
Thank you, Representative House. Diane, and then Senator Wilson and Ombudsman Beverly.
Hi, this is Diane. Just briefly, and I've been in and out of the conversation. I do have a 3-month-old sitting next to me who's decided he's very vocal today, so we'll see what happens. But one of the things that assisting unpaid caregivers, obviously people would like, it seems that people would always like to stay in their homes as long as possible, be with their families, be in their environment that they know and love. However, modifications to that environment do come up that may need to happen, whether it's repair of the environment, whether it's changing the environment to help suit the person who now is dealing with dementias and their family. And so support, whether it's tax credits or whether it's reimbursement, some sort of allowable expense reimbursement, it is certainly something that would help people not put off repairs and change to the physical environment, not put off buying equipment and making do with things that aren't really appropriate for the situation. So including something that's a bit more robust than anything they may be able to avail themselves of now is one thing. However, when I was listening to Representative House, it does seem to me that whatever we can do to destigmatize one, growing older and having a dementia, and two, destigmatize having to care for our loved ones, making people more comfortable with care of their loved ones, ongoing care. It seems to me that there are a number of us who have always thought, well, that won't be me as I get older. I'll be able to put that off. I won't get a dementia. I won't whatever. So making this something that's all part of life. And I don't know how we go about doing that, but one is education. But another is making this something that the community is very involved in. So I don't know where we go with that, but making communities, taking a community to not only bring up children, but to care for our elderly and disabled.
Thank you. Thank you very much, Diane. Senator Wilson, are you on the phone today? Okay. Ombudsman Beverly, I think you were able to join us.
Yes, thanks very much. And I want to demonstrate I am riding, not driving. So,
and would you like a little bit of context for the question? Would that be helpful?
I think I've been listening for a while, so I think I have a few ideas here. So there's been a lot of talk about reimbursement, and we have many provider representatives on the task force, and so not surprised. And I just want to say, I'm all about providing sufficient funding to provide quality care. But some of the corporate structures are so complex that they really are diverting funds from the wages of the people who are really providing the care. Case in point, we had a phone call with a provider in the last couple of months of a facility that had converted from a nonprofit to a for-profit facility. And we started receiving complaints in the Ombudsman office about issues with staffing primarily and care deficits. And the owner of the facility said to us, well, the nonprofit had too many staff. You as Ombudsman need to understand that a for-profit facility can't have that many staff. So that's just an example of how those complex corporate structures become an issue when we're talking about wages for the people doing the work. And, a living wage is important, but we also need to make sure that we're respecting caregivers and treating them well. We've heard in some of the previous comments about turnover, and as Greg said, about leadership. That is critically important, that it's not just the turnover. I think the turnover of direct care staff is a symptom of turnover of administration. We have rapid turnover of administrators in many cases. And so any training and leadership that has happened and progress that has happened in the culture of the facility can change overnight because of a new administrator, a new director of nursing, or a new social worker, for example. We haven't really, in the short time that I've been on, we haven't talked a lot about real quality. I did hear some of that with regard to quality measures. But one of the things we really need to look at is standards for memory care and units. A lot of people talk about units in long-term care facilities, and in way too many cases, a unit is simply a lock on a door, and we have to stop locking residents behind doors. People think that if they're going to an assisted living memory care unit, that they're going to get something special. And we have thousands of complaints every year telling us there was nothing special about that memory care unit. Let's see. And then just wanted to kind of emphasize what Tina said about transitions of care. That's really important. A long-term care facility, for example, or even a home care provider that is providing excellent care to a consumer with dementia is only good where the care is being provided. So if EMS comes, and they're not familiar with the person with dementia and so on, that creates an issue, and those transitions of care are difficult. So I think that those are my primary thoughts about the topics that are on the slide. Summarizing, just really focusing on real quality, some standards for memory care, thinking about the structure of long-term care facilities, and respecting the workers. Thank you.
Thanks so much, Beverly. Let me check and see whether Sally has been able to rejoin. And let me check and see if Representative Creech is back on the phone. Okay, and Doug, you have a hand up. I don't know whether that was left over from before or whether there was something you wanted to add.
Well, it came up with Pete about half an hour ago, but there is something.
Pete was eating?
Yeah, boy, that sandwich looked pretty good, didn't it? There was something, a couple things I wanted to add. First of all, and Catherine remembers this better than I do, we were on a task force a year or so ago, actually it's longer than that, 2 or 3 years ago now, with Polanda that had many of these same issues in it. You may want to go and see what they submitted. I think go a long ways in helping us look at the different things. One of the things they looked at was dementia training. Right now, as far as workforce issues, I don't know that we do the MyCare programs as well as the Passport program and the Assisted Living Waiver program. My agency alone case manages 10,000 clients a year. non-duplicated count. And what we're finding is that we have statewide as many as 3,000 people who we can't serve because there aren't people to put the services in play. And our group alone, we're 70% of the 22% of the state, 70% of our areas in Cuyahoga County, 7% of our clients. And we have probably 600 people we can't serve because of workforce shortage. So the workforce shortage, typically for those of us that's been in this space for a long time, when you have a recession, typically we have a lot of people that will come and we can hire people. When things are good, we're in a space like this, but I've never seen a recession and a workforce shortage at the same time.
Thanks, Doug. Did I miss anyone?
Oh, just one last thing. The last thing that came up in this, it was Palanda's group that did it. We asked a couple legislators, if you have a child care credit, why can't you have a senior care credit? And
we may know this, I may have seen it, but Doug, can you just spell that for me really quickly? Palanda's? Take again. Somebody take
You're asking the guy that never won a spelling contest.
It's P-E-L-A-N-D-A.
That's what I was going to say. Thanks, Pete.
Right.
And she had giant notebooks of stuff.
Yeah.
Okay. Thank you. Just making sure we have we know exactly what we're looking for and we can look for that. All right. Thank you all very much for that information. I'm going to turn over to Yonda for a few minutes to talk a little bit now about, given what we've just learned, what do we know about the data that we have? What do we know about data we might not yet have or need? And do we have any conflicts with data?
So I don't think that there is anything that conflicts. So, I mean, that's a good thing. We do still have some inadequacies, and let me kind of touch on those. And there's a slide in the packet for this, but we were unable to get any data at all about geriatric psych units, and it's unclear today, where is the regulatory oversight for these? Where are those regulations? Where are these units? That feels certainly like a really big gap to us, but many of you have spoken fluently about transitions to and from geriatric psychiatric units. So, if you can point us in the direction of data and information about these, we would be very, very grateful, because, we can then hopefully use that data.
They're licensed by the Department of Mental Health and Addiction Services, and that's where you should go for any information that is available about them.
Is there an actual separate licensure category for these?
Yes, they license psych units. Now, not just geropsych, it's all psych units, but they should be able, I would think they'd be able to give you something on geropsych as a subset of that.
Okay. Where are they? Are they usually in private hospitals, or are they freestanding? Are they part of the state mental health system?
All three.
All of the above, okay.
All the above.
Pete, this is Jill Earl, and I'm the official minute taker. Can you repeat the name of that again to get where we go get the information?
The Ohio Department of Mental Health and Addiction Services. Director is Lori Chris. She's a former exec of the.
So that's helpful. Thank you for that.
Sure.
Thank you.
We will continue to work on the workforce data and collecting. I think some important points have been raised here that are a little harder to quantify, but I think that they are important. And I certainly know from my previous background in organizational development, the importance of culture and workforce practices that are also part of the workforce challenges. Reimbursement is part of that discussion, but it's not the end all be all. So we will continue working to gather data, but I really strongly suspect that we're going to see a finding around the lack of data in this area, the lack of good usable data for Ohio to build on, and the need for some data collection systems in this area. We did include in the packet the state policies for dementia-specific training around in residential care facilities and skilled nursing facilities. Highlighted a couple of things that we felt like were important, and I think I think we can develop some findings around that. We didn't really. There is actually a lot of information in the packets about the reliance on caregivers and the dollar values associated with private caregivers. So I think we've got some data to collect about and it's part of our data request that is pending with the state about the availability and funding associated with caregiver supports that will help us, look at adequacy. One piece of data that you are not seeing yet, because it's something that we are just sort of working on ongoing, is we created a spreadsheet that has all of the counties in Ohio, and we're really trying to lay out an enormous amount of data just on a county basis to see if there are some geographic correlations. I heard a little bit about that when we talked about, there was some discussion about the levy earlier, and some inconsistency of resources because of the varying local levies. But we didn't really hear anything in the discussion about a lot of geographic disparities. The other thing is, and this didn't really come out in this portion of the discussion, but we will continue to work on, finding and applying an equity lens to this data to determine if there are challenges in accessing services based on demographic factors such as race or neighborhood. So, I think you've pointed us in the direction, but again, as I said before, there are gaps, and any resources that you can point us to fill those gaps would be very helpful. That if there are resources that you are relying on, I think that one of the places where we have gaps, and there's a request pending, is looking for information about in facilities, survey results, complaint numbers to ODH, reports of abuse, neglect, maltreatment. Those are gaps in our knowledge that would contribute to the overall picture of the state of care in the facilities. And so certainly, Ombudsman Lauber, you may be a resource for some of that information. So I think I can sort of pause there and turn it back over to Leanne.
Thanks, Shonda. So I'm sitting here sort of playing around with time and best use of the last 40 minutes that we have. Again, we've been sitting for 45 minutes, almost an hour. So in a minute or so, I'm going to suggest we take a quick stretch break, just so you know that's coming. I'd like to take, so what I'm thinking is I'm going to take a quick break.
Can I add one thing really quick? This is Doug. There are tremendous gaps between the inner city areas, the urban areas, and the rural areas.
Yeah.
Particularly in my care. And the reason for such a tremendous gap is it's very hard to serve so many people at a distance, whereas in a major city, you're going to have a concentration. So the numbers don't work for the caregiver, they don't work for the agencies, and they don't work for the home health businesses. So you may want to talk to somebody in that space just to help you understand exactly what's going on out there.
Thanks, Doug. In fact, I was going to ask if there was anything else to add. So thank you for sort of queuing that up for us. I just sent a note to Yonda about the Area Deprivation Index that may give us some information. I can't remember if that's a public document. It was a document that we developed and we used when I was with the Lewin Group. I think it's now since public, but we'll see if we can take a look at that. That would probably provide us some additional information.
Can I interject as well?
Yeah.
And note that, Doug, if you have a person that you can point us to, we would certainly appreciate that, because, Director McElroy indicated that, we are looking to build sort of a standing pool of experts, but we're also looking for key informants that may be able to just provide some pieces of information that we need on a more immediate basis. So again, if you have somebody that you can point us to that's not part of the task force, we certainly would information.
Nina Keller is the AAA director in Rio Grande. I'd start with her.
Okay, thank you.
Thank you.
This is Jolene from Department of Health. I just want to mention with the previous comment about the survey data and the complaints, I am kind of working with that with our Bureau of Long-Term Survey and Healthcare to kind of look at all the data that we have available that we could provide. So that is kind of in process.
Thanks, Jolene. And I see Bonnie's hand and Jean's hand. So Bonnie?
Just very quickly, I wanted to follow up on Yonda's request about the geriatric psychiatric units. Mm-hmm. And if you go back to everything related to House Bill 470, that about memory care units and the discharges to the psych units, you'll find quite a bit in the minutes about that. And I know that Doug and Pete talked about the task force, which was, just so you know, the formal name of it was out of the House of Representatives. It was the Speaker's Task Force. And there was quite a lengthy discussion about geriatric psychiatric units there as well. So thank you.
Thank you, Bonnie. You had sent me that information, and I have to confess, I think that I might have missed that last week. So I appreciate the reminder, and I will go back to that. Thank you.
And Jean had her hand up. And Jean, this is Leanne. I was just going to answer a quick question. I forget which slide I had up. Sorry for scrolling. If you're looking at the slides, it'll make everybody dizzy. I think it was this slide. The language from this slide came, my recollection is I took it right from SB 24. I might have broadened a little bit or taken some license with the titles of the bullets, but I know you were just asking about residential care facilities kind of being separated out from HCBS, and I believe that was just a call out in the actually in the Senate bill. So just so you know that. But you had your hand up, so let you share.
This may have been taken care of by Jolene from the Department of Health's comment as they develop that information. I think it's important. It's just not the number of complaints, but the number of substantiated complaints. Meaning, because health is actually the group, if there's a complaint, by law, they're required to go out and look at the situation, and they determine if it was a substantiated complaint or not, meaning it happened.
Thanks, Jean. And I see Beverly's hand and somebody else, but I can't actually see who it is on here. So if we start with Beverly, and then I'll see if I can figure out the second person.
Thanks. Just a follow up on Jean's comment. Yes, that's right. About the substantiated complaints, but I think it's also important to note the number of complaints, because even in the Ombudsman office, if we're not able to verify a complaint, it still represents someone who was unhappy. And so maybe for the health department, maybe they weren't able to find a regulatory violation, but it doesn't mean that the situation didn't happen or the person was, making it up. It indicates someone was not happy about something, and it might not have been something that is subject to a regulatory requirement, so they couldn't cite them. So I just want to make that point, that the number of complaints is an important factor.
Definitely a metric. Thank you. And I think, Bonnie, you have your hand up?
No, I think I forgot to take it down. Sorry.
Okay, that's okay. Anybody else have a hand up at the moment that I can't see? making sure I'm not missing someone. Okay. Well, what I'm going to suggest is, let me see, any other comments? Really quick. Okay, what I'm going to suggest is, I'm sorry. Did I interrupt somebody? Okay, we'll take a quick break, and then so we have one more topic that we wanted to cover today, but we also have some few logistics and announcements sort of things to cover at the end, particularly around this discussion of the public forum. And I really want to give Yanda a chance to just sort of hone in on any of the conclusions that we heard and kind of reflect those back to make sure that we've captured all of those. And I'm thinking those two things probably require about 15 minutes of time. So that gives us about 15 minutes total. We could start kind of a quick conversation about the personal and public safety and legal issues. Maybe just talk about the personal and public safety, very high level, and then we could come back to it at our next meeting. I'm remembering and sort of reminding us that we lost about 20 minutes of this kind of work group time at the beginning today because we needed to kick off with Director McElroy, and we had this sort of kickoff process, and we'll gain a little bit of that time in our next meeting. So I feel like if we don't quite finish this third conversation today, we'll have time in the next meeting to pick it up, given I think how well this went. And I'm really, really thrilled with kind of how far we've gotten today. So I'm going to suggest, I have at 11:28 on my clock. Let's take a 2-minute break, stretch. We'll come back and start at 11:30. I'm going to stop presenting for just a moment. Okay. Hi, Sally, welcome back. Okay, I'm going to go ahead and get started. And let me reshare again here what I have on my screen. All right, so in the kind of theming of buckets, we pulled together the public safety, personal safety, and legal issues to address into one bucket. They seem to us to be very interwoven. Please, if that does not make sense to you, let us know. Again, this is your report, and so we want this to reflect exactly what the priorities are for all of you. for the moment, the two pieces of data, I'm going to share this really quickly because we only have 2 slides for this. Our 2 pieces of data are specific to guardianship issues in Ohio. 61.5% reporting that guardianship caseloads have increased, and only 4% closed because of return to competency. That to me is a personal interest because of the work being done around the country with supported decision making. I'm really intrigued to learn more about that and hear about recommendations as somebody who works in that area. And then just the second piece of data is kind of what the challenges are being reported around kind of managing adult guardianship. So these aren't new slides. You have those in your packet as well. I don't know that we will be able to get through everyone. I did some random numbering again. You can, I would say, if you can weigh in about a minute. And if we need to come back to this topic, we absolutely will. This is probably one that we need to dive into and will take longer than we have today. So I'm going to start with Joe and then go to Pam and to Bonnie. So can we start with Joe? Thoughts around what's working well, what could need improvement, and do you have some conclusions? Those are kind of the 3 questions.
Yes. Well, I don't want to sound cynical, but I think that the place where we're doing well is we're coming around the table to have a conversation about what needs to be done. I think the conversations I've had with our members, there's not a ton of I think, bright spots, to be honest. I think there's a lot of work that needs to be done. So I'm sorry if I kind of sound disparaging, but and then what was the second piece again?
So the sort of, the context for the conversation is though what's going well and you want to keep doing it. What do you feel it needs improvement? And out of that, what conclusions do you draw? What would your findings be?
Yeah, so I think it goes a lot with what I've already said. I think there definitely needs to be some additional support for individuals. I think there needs to be more funding support for providers. And I think that we need to continue to look at creating standards in training across the board. Obviously, we're specific to home and community-based care, but giving some providers more direction on what good care looks like for people with Alzheimer's and dementia-related diseases is really important. So I'll leave it there. Great. Thank you.
Thanks, Joe. Pam.
Yeah, so I'm going to echo all that. I agree 100%. I think we need a lot of help, a lot of resources. I want to really look at those family caregivers at home and ensure that they have resources in front of them. I think we all mentioned they're Googling things and all of that, but if there could be some campaign or something that is so visible for them to follow. And I think that's it. I think that other than I'll add that I felt good about the people or the resources that our task force spoke to. We spoke to someone representing all of the providers except for the hospitals. And I felt their input was valuable, but it was very common. There was a common thread, and it goes back to that, the training and the quality of the training. And so definitely for me, that's something I think we need to really, really look at hard. Thank you.
Thanks, Pam. So we're going to go to Bonnie and then Greg and then Melissa. Bonnie?
So briefly, thank you. My perspective is a little bit different, and that is I think we have some wonderful partners who would like to be of assistance here. I think Ohio's judicial system, our guardian system, and our probate system in addition to our law enforcement system, are very, very interested in being involved and tackling this, and some have already started. So I think there is a really good foundation there. The thing that I would like us to be careful about moving forward is, as we are able to, and as we are diagnosing dementias earlier, and that we are talking about sometimes mild cognitive impairment, we have to be sure that we aren't thinking about a one-size-fits-all answer, meaning once you have dementia, you can or can't do X, Y, and Z. And so it is those nuances that I think will be the most important going forward. Thank you.
Thanks, Bonnie. And I lost my, oh, sorry, Greg, number 4.
Yeah,
Greg and then Melissa.
Yeah, no problem. I really have nothing to add to this outside of what was already said, so I'll leave that time for somebody else.
Okay, thanks, Greg. Melissa, are you still with us? Melissa, if you're saying something, you're on mute. Okay, I will loop back, or we will capture Melissa's input next time if we don't get back to it today. Let's see, I'm going to go to Representative House and Diane. Representative House, are you still with us? No, and it looks like, Diane, it looks like in the chat, Diane may have had to leave. Diane, are you still here? Okay, how about Catherine and then Lisa?
Thank you. Bonnie mentioned not having a one-size-fits-all solution and the importance of being very flexible and nimble to have different resources. And we talked a bit in our committee about EMS and the training that they have. There is some training that's provided there. We know that there's training provided for banking personnel, but I wonder about the Ohio Chamber being another partner, because we need restaurateurs, we need car mechanics, we need across a range of businesses an understanding, not simply of knowing the correct response to an individual wherever they may be with that dementia, but also appropriate next steps. And for example, I think it was Beverly Laubert who mentioned that when we have, when we're using the silver alert and that individual is found, is there a next step? Is there an understanding of now how to support that individual? That clearly there's a situation that needs to have some action, and are people equipped? So how do we come across a range of our businesses to help provide support?
Thanks, Catherine. Lisa. Lisa, we lost your sound.
I was expecting you all to read my lips. Sorry.
There you go.
I was just saying that one of the issues I think is end of life choices. And so, you know, it sort of goes along with the whole communication process. But if a diagnosis is received, no, it doesn't immediately take away your rights to make decisions for yourself or give rights to your family member, even if you sign a power of attorney or have to go the way of guardianship. But having those kind of documents discussed in earlier on in the process so that they are ready if and when they are necessary, I think could be incorporated as part of the plan.
Thanks, Lisa. Beverly.
Thank you. Yeah, a few comments just by way of background. The Supreme Court has a subcommittee on adult guardianship as part of the Committee on Children and Families in the courts. And that committee I'm a member of, we worked on development of the current guardianship rules of superintendents, and there were definite improvements there, and we were working on standards, and then there was a very big expose in the Columbus newspaper about guardianships. It was a multi-part series that really pointed out some serious failures in the system. And I believe that many of those failures have been remedied, but there's still a ways to go in terms of sort of like what Lisa said about making sure people understand the scope of the authority that they're given, and that we always go back to the individual first and focus on their preferences to the extent that they can express them, and use substituted judgment whenever possible, rather than just taking away someone's rights and making decisions for them without real knowledge of what their life history is and their values. So I think we still have a ways to go, but there have been definite improvements, limits on the number of people that one guardian can have under their authority and so on. We used to have one particular guardian in Ohio that had 400 people, and that has been limited. So we should really engage the Supreme Court subcommittee on adult guardianship in some of these conversations as needed. And then with regard to law enforcement, Catherine hit the nail on the head with regard to the missing adult alerts and the concerns about where is the follow through when someone has been found. Fortunately, most people are found when they are missing, but where's the follow through? How do we bring some services to that person and to that family, those caregivers, to make sure that they can remain in the community as long as possible and get the support that they need. So right now, the missing adult alert system is under the auspices of the Amber Alert system that started about missing children. I think we need some greater input and focus on older adults. Right now, we only have one person. It's someone from the State Ombudsman Office who is a member appointed by the governor to that Amber Alert Advisory Committee, and I think we need to rethink that. That's all I have. Thank you.
Thank you. I'm going to go to Leanne, and then Pete and Sally.
Great. Yeah, I, not to sound like a broken record, but I agree with all other comments that have been, added to this subject. I think just one other thing that kind of stands out to me is respecting those who are struggling with dementia and Alzheimer's, is just respecting their dignity. Sometimes I know from personal experience, you're out in public, how do you, it's very hard to say, well, you have to excuse her, she has Alzheimer's or she has dementia. I don't know how you address that or how you, and certainly a lot of us have probably been there, but just respecting their dignity as we look at, all aspects of safety and legal issues. And again, maybe that's not a regulatory thing or a policy thing, but just something that I guess I just want to mention to keep in mind through this, this point.
Thanks, Leanne. Pete, and then Sally, and then Doug.
Yeah, just a couple comments with my association hat on. I know that, I hear from members fairly frequently about difficulties about, getting guardianship for folks that really don't have anybody, that don't have any relatives that are involved or things like that. And that goes back to what Bev was saying about the problems here in Franklin County with, non-related guardians. Then taking that hat off and putting on my personal hat, and this goes back to what Catherine was saying, and somehow we've got to get more involvement from general businesses and entities that are out there and are interacting with people who haven't gotten to that point, but are getting there. And my mother was an example of that. She had a situation where a couple of women came to her door and were soliciting funds, and they ended up driving her to her bank, or she drove them to her bank. She went in and took out she got $9,700 of cash, which is just under, the $10,000 limit. And then she took them next door to Home Depot where they were going to go buy flowers or something. And of course they disappeared. The bank was just like, whatever, this is not our problem. And it's like, somehow that shouldn't have been that way. And they actually took her to not her normal branch, because her normal branch, actually, they would contact me anytime, and I wasn't her guardian at that time, but they would contact me anytime she came in and did something strange, like one time she ran into the ATM machine in her car, and but this was a different branch, and so they didn't have that kind of warning. So it's like, could that have been spread around a little bit to the different branches, where she might go, or I don't know. So I think there's really a need there. And it's kind of like that before we get into formal care, but somebody who's clearly living with dementia in the community.
Thanks, Pete. Excuse me. Thank you. Thanks for that story too. I think it just reminds us that for most of us, this is really, really personal work in addition to professional work, and we have a real passion about it. Thank you, Sally, and then I'll go to Doug and Trey.
Great. So to not repeat people, I agree that we've made some good strides with guardianship programs and the Ohio Adult Missing Alert Program, but I think there's next steps that we could move forward with that, and first responders in regards to training. A lot of counties have Project Lifesaver, so how can we work with that to complement next steps? Another area that I think is inconsistently funded and supported that plays a critical role in safety and legal issues of adult protective services. I know in some counties it's half a county worker who's also doing children's services too, and I just don't know how that happens. So looking at what we could do to put better APS systems in place for people. There's been some interesting, a couple counties have prosecutors' offices that look at APS issues too, and I think are pretty well educated on dementia care. I think there's a couple counties throughout Ohio that do that. So maybe look at building upon those models too. What Catherine said about businesses, I think stores, sometimes people going to stores and getting lost and not knowing how to get home. We hear stories about that, or maybe picking up things and taking them home, and then people getting addressed with issues with shoplifting can be addressed very, very differently, particularly if someone's having some cognitive issues. And I do think the whole issue with choice and decision making and making sure the individual who's experiencing the cognitive impairment has some role in that is very, very important. I think there's been some interesting studies that were out 10, 15 years ago that people still can make choices and have some impact in their decision making, even very well advanced into the disease, and making sure that's integrated in the work that we're doing. The other thing with safety I think about too sometimes is and this might fall more into health issues, is related to falls, and falls is one of still the leading causes of death with older adults. And so there's some great evidence-based programs out there for and how could we be integrating them more, from a prevention standpoint, particularly. And I know that there's been some issues with balance with early cognitive impairment. And so how could we tie all that together too? So I'll stop. Sally. I think I'm past my minute. Thank you.
Thanks. Thank you. And I just want to check really quickly. I, on my list, have Doug, Trey, Lori, and Jean. Am I missing anybody else? Okay, so Doug, Trey, Lori, and Jean, and we're going to go as fast as we can, so we end up with at least with a few minutes to wrap up. Doug.
My concern always was the traffic stop with someone with dementia. If you go ahead and send them home, that's a bad decision on the police part. If you go ahead and take away their car and call somebody, that's a bad decision. And if you go ahead and take them to a facility or to a police station, that's a bad decision. So the question is there some mechanism that you can get agencies more involved than not in trying to get those things involved? And then my quick story with Pete is my mom decided that she was going to refinance her house and didn't tell anybody. Took out $55,000, and we asked the lawyer if we can get her declared financially incompetent. And he said, well, would she be determined incompetent in other areas? And we said no. And so he came back, well, you can't litigate against stupid, is what he said.
Wow.
that was a bad place to be. So.
Yeah.
But the point is a legitimate one. There has to be safe guards in the community like Pete had before, where the bank would tell him what was going on ahead of time, and we lost that with my mother as well.
Yeah. Thank you. I'm sorry for that story. Thank you for sharing that with us. Trey, are you still with us?
Yes, I am. I think that one of the things I think around just guardianship overall, I mean, we haven't weighed in on that too much, but it needs some work in Ohio, and especially as it relates to just mandatory reporters, making sure that they're reporting the type of information that was brought up, obviously, by Pete and Doug, to the family. I think that's huge. I think one of the things we worked on a while back, even when I was at ARP, was that we had just put in the EHR record a family caregiver or a loved one that, if that person showed up at the hospital would need to notify that caregiver that, hey, your mom or your dad is here, just as a safeguard. So I don't know if there's an ability to do that as it relates to banking and other things, but I think that's an example. As it relates to missing adults, I agree. I think that there needs to be some additional work, or even trying to identify kind of the follow-up. We've seen this a couple times with families. There wasn't really a follow-up after their loved one was found, and then the problem continues to happen in some cases. And the family's kind of just like, okay, well, what do we do? So what does that follow-up look like, and how does that work? As it relates to law enforcement, we have a bill, House Bill 23, that's currently in the Senate that addresses law enforcement training at the schooling level. However, one of the things that we did not include in that legislation was adult protective services. They probably need to be also included and be well resourced at the community level to be able to work with families, because I think that's one of the front line of defense areas where people can get assistance. So that's kind of where we're at.
Thanks, Trey. Lori and Jean, I'm still going to give you really quick time, and I'm just going to say we will come back to this at the beginning of our next meeting, so remind you of that, get that data back out, just so we can not feel like we're rushing folks through toward the end here. So Lori and Jean. Lori, are you still on the phone? All right, and Jean.
Thank you. I'll just go I think it's been wonderful comments on this section, and I agree with them. I think that one thing that wasn't mentioned in this, Representative House mentioned it, I can't remember exactly when, but back, I would love to see something in the schools, just a small segment that alerted everyone at a point about dementia, because it means that the carry-out grocery store person, the checkout person, all of those persons would at least have a little understanding. I think people even brought up, waiters and waitresses. I think if you build a little understanding through a piece that could be put in the school systems, then you create greater compassion in people. And maybe we can even move to more of the things people were trying to say in this, that we'd like to see a more compassionate society in this area. But I think the numbers, unless some miracle happens, are going to be so large, it wouldn't be a bad idea to have a segment just to make children, even young adults, aware of it. I'll stop there. Thank you.
Thank you, Jean. Did I miss anyone? All right. Well done, team task force. Great job. I'm going to hand the baton to Yanda to do a quick reflection on conclusions, briefly touch on the forums, and Yanda, you can request the motion to adjourn whenever we get there.
Okie dokie. So one of the things we had talked about doing today was sort of summarizing the discussion and providing you with some takeaways from the discussion as far as findings that came about as a result of today. But in reality, that's a little premature. We have 4 different note takers on today's call. All of us have been busy, 5 if you count Leanne as well. All of us have been busy collecting comments, information through the course of the conversation today, through the course of looking at what's been in the chat. And in about 15 minutes, we're going to put our heads together. And I think we will then summarize common themes and findings that come out of that conversation that we will then push out to you guys in a separate email so that you will have an opportunity as a group to review findings, or at least findings to date, and respond to those. So stay tuned for that information, because that's going, I think we said a couple weeks ago that we're going to have multiple trains running down the track. And one of those trains is writing the report. So, being able to summarize findings early and pointing ourselves toward the data that is part of supporting those is a critical piece of writing that report. As far as the public forums, Director McElroy indicated that we have identified a week, and it looks like right now that week is going to be the week of July 13th. And we're looking at July 13th, 14th, and 15th as the days when there will be public forums. All of the task force members will be invited to observe those public forums. We are going to ask all of you to help distribute as soon as we finalize the dates and the times for these, as well as the themes. We will be asking the task force to support this effort by distributing information and helping to identify people that should be invited to provide information at those sessions, so that we can actually get invitations to people, but we aren't excluding this or we aren't limiting it only to invited people. If there are people that come forward, we'll certainly want to get that input as well. We think this is the first round of public input, and that there will be a second round of public input of similar duration that will happen in August or September. That will be part of developing the final report that will be taking place in November. So this is not the only opportunity. We do expect that this particular round will be somewhat structured. There will be a theme around each of the time slots, and we will ask presenters to please present their information to us in writing so that we have that for the record. Probably have to impose a time limit for that. So stay tuned for more information about the public forums, but that is the tentative plan with more details to be developed. The takeaways for you guys though is think about how you might distribute this in your networks, and think about individuals that should be invited specifically to testify. So with that in mind, I think I will, my clock says that it is 12 o'clock straight up. If there are no objections or any further questions or comments that we may or may not be able to answer, I am happy to go ahead and move for adjournment.
I'll move that the meeting be adjourned. One quick comment though, I think you guys did a wonderful job today. Thank you very much.
Thank you.
Thank you.
I'll second it all.
Thanks. We appreciate your presence and participation in this. So we look forward to next week.
Absolutely.
And stay tuned for a lot of information coming at you by email. We'll be sending out summaries of findings. We'll be sending out information about the public forums, and we'll be sending out information to prepare you for next week's meeting as well. So lots happening. Thank you.
And I'm just going to ask Alex if you could stay on for just a moment, because I need to ask you a question about hanging on to the chat. Since it's being live streamed on YouTube, we don't capture the chat, and we need to figure out a way to do that. If Alex is still here and can help with that. Thanks, everyone.
Thanks all.